biomedical image processing course. In this module, we will try to cover carrying out different phases of the research related to diabetic retinopathy. The process of developing a medical test begins with small exploratory studies that seek to identify how best to apply the test and whether or not it has potential for use in the practice. At the end of the process, there are studies that seek to determine the value of the test when applied in particular population. Unfortunately, evaluation of most diabetic retinopathy, computer-aided diagnostic software and algorithms or combination of thereof never gets beyond the first phase. Much can be learned from the procedure developed to evaluate new drugs, with the caveat that narrow inclusion criteria of drugs trials narrow the applicability of their results to unselected population. So while selecting, it should be of in a proper order. What now follow is an introduction adopted from Pepe. Phase 1 is an exploratory investigation intended to identify promising test and setting for application, usually performed on subjects from the convenience sample. People with diabetics with or without diabetic retinopathy and or STDR attending a diabetes clinic. Phase 2, retrospective validation, determines if minimal acceptable sensitivity and specificity are achieved, ideally in a population-based sample of disease and non-disease subjects, that is, the time to reach out to primary care which are necessary to get to the subject. Phase 3, retrospective refinement, determines criteria for screen positivity and covariates affecting ROC, comparing promising tests and developing algorithms for the combination of various tests. Subjects are a large random sample from diseased and non-diseased subject. Phase 4, prospective application, determine positive predictive value and false referral probabilities when the test is applied in practice using a cohort study design. Whereas in phase 5, we have to concentrate on measures disease impact, which determine effects of testing on cost and visual loss and effects associated therewith, associated with diabetic retinopathy and STDR type of retinopathy in a randomized prospective trial comparing the new test with an existing standard of practice. For each phase, there are specific methodological issues that you and your statistician need to consider at the earliest possible planning stage. If we follow the method as per the traditional process and statistician, we can get maximum accuracy. Now we will see an example from another field which may be need to study while developing a software and a tool for diabetic retinopathy. The impact of computer-aided diagnostic on the performance of screening mammography has recently been analyzed, with the alarming result is achieved through that process. Some background information is necessary before an important recent paper is discussed. Mammography is unprofitable or radiologist in the United States. Mammograms are read by radiologists of widely varying experience. Double grading, mandatory in many European countries, rarely occurs in North America region of the worldwide population. Numerous possible reasons have been suggested for the great variability of false positive fraction and lower specificity than reported other countries. Reported for North America, many of those reasons also apply on diabetic retinopathy screening and re-examination program. Screening mammography, the most common basis for lawsuits in radiology, is a particularly stressful task for radiologists associated with relatively high rate of burnout. Computer aided diagnostic software developed by R2 Technologies was approved by FDA in 1998. Medicare and many insurance companies now reimburse for its use for the process of diagnostic. Within 3 years after FDA approval, 10% of mammography facilities in the United States had adopted worldwide. The association between use of computer aided diagnostic tool and the performance of screening mammography from 1998 through 2002 at 43 facilities in 3 states was determined for 429,345 mammogram samples of the different subjects. It seems the widely used of mammography for the automated process of diagnostic specificity and PPV decreased after implementation, while sensitivity increased insignificantly. No more cancer were detected. Accuracy fell. Area under the ROC curve 0.871 versus 0.919. Increased frequency of recall and increased false positive fraction may have been related to increased indication of ductal carcinoma in situ. Its hallmark of mammogram, which cluster microcalcification detected by the software which is used in CAD, a condition that develops more slowly and is less dangerous than the invasive cancer process which is followed for the detection, with the goal of altering radiologists to overlooked suspicious areas on the mammogram. The CAD software inserts up to 4 marks on the average screening mammogram test. For every true positive mark associated with underlying cancer, radiologists encounter nearly 2000 false positive marks of the data which is collected during the process of mass examination. In other words, signal to noise ratio is unacceptable poor. That is a very stressful situation. One hopes that latter version of the software are more accurate and more correct to diagnose the positive results. Diabetes is an increasing health problem both in United Kingdom and rest of the world population. Approximately 1.4 million people in the United Kingdom are known to have the diabetic subjects among current population. One of the most feared complication of diabetes is damage to the eye. It is estimated that people with diabetes have 25 times greater risk of going blind than non-diabetic population. Each year, around 12% of patients in the United Kingdom who are registered blind have diabetic eye disease as a cause behind to lose their vision. Diabetic retinopathy is the leading cause of blindness in the population of working age in the United Kingdom and developed nation, and is of increasing importance in developing nation worldwide, where we have to consider this for alarm situation. Everyone who has diabetic is at risk for developing diabetic retinopathy among that population, but not everyone develop it. It is estimated that at any time around 10% of patients with diabetics will have diabetic retinopathy requiring appropriate treatment. The great majority of diabetic retinopathy complication can be prevented with proper examination and treatment plan for the subject. The chemical changes caused by diabetic affects retinal capillaries, the smallest blood vessel linking arteries to vein. This progressive damage is called diabetic retinopathy and occurs due to a combination of microvascular leakage and microvascular occlusion. Diabetic retinopathy is conventionally classified according to the presence of clinical lesions indicating leakage or occlusion and their position in the eye. The three main forms are known as non-proliferative diabetic retinopathy, maculopathy, and proliferative retinopathy. The form of diabetic retinopathy caused by microvascular leakage away from the macula is called non-proliferative diabetic retinopathy or NPDR and is shown by the presence of sacculation from the capillaries walls, microaneurysm, blood retinal hemorrhages, lipid exudates, hard exudates and retinal edema occur on the subject. This stage of the disease often has no obvious warning sign and patients are unaware that they suffer from the disease until it progresses to more severe level. Detection at this stage on the purposes of this work may allow treatment to prevent the future complication for the patient. When this microvascular leakage of edema, blood and lipid occurs in the central region of the retina, which is called macula, it results in blur vision for the subject and is called diabetic maculopathy. Macular edema is the most common cause of decreased vision in patients with non-proliferative diabetic retinopathy. Less often, microvascular occlusion can also occur at the macula causing impaired vision because of an inadequate blood supply to that area. It has few clinical signs and is not usually treatable. Sometimes there are extensive area of microvascular occlusion throughout the retina. The retinal tissue, which depends on those vessels for its nutrition, release the vasoproliferative factor, simulating the growth of new abnormal blood vessel where the normal capillaries have already closed, which are used to carry the nutrition for the retina. This form of diabetic retinopathy caused by closure of capillaries and growth of new teeny vessel on the surface of retina is named proliferative diabetic retinopathy. It may result in bleeding into the cavity of the eye and scarring with loss of vision. Non-proliferative diabetic retinopathy is the most common type of diabetic retinopathy, accounting for approximately 80% of all the patients which are up till now examined suffering with this type. It can develop at any point in time after the onset of diabetics. A qualified practitioner such as a general ophthalmologist may detect these changes by examining the retina of the patient. The physician looks for spots of bleeding, lipid exudation, or areas of retinal swelling caused by the leakage of edema, and will be more concerned if such lesions are found near the central retina called macula of the retinal vision, when vision may becomes affected. Accurate assessment of retinopathy severity requires the ability to detect and record the following clinical features. Number 1, microaneurysm. The earliest clinical recognizable characteristics of diabetic retinopathy is called microaneurysm. Retinal microaneurysm are focal dilation of retinal capillaries. They are about 10 to 100 microns in a diameter and appear as small, round, dark red dots on the retinal surface. The number of microaneurysm increases as the degree of retinal involvement progresses among the diabetic subjects. Next one is called hemorrhages. As the degree of retinopathy advances, retinal hemorrhages become the next lesions on the retina of diabetic subjects. Retinal hemorrhages appear either as small red dots or blots indistinguishable from the microaneurysm, or as larger flame-shaped hemorrhages. As the retinal vessel become more damaged and leakage, so fluid come out of it and it will spread on the retina. Their numerous increases. Carrying out different phases of research. Along with this, we have seen in this module an example from another field like mammography. We have compared outcome of mammography with automated software in the retinal disease diagnosis. We have also come across with retinal markers for early detection of eye disease. Along with this, we summarized non-proliferative diabetic retinopathy detection and grading mechanism in this particular module. In next module, we will see various lesions detection and their grading mechanism. Thank you very much.